So we've got a lot to do today, and I don't think we're going to get through with it all. So whatever we don't get done with, I'll record in my office or in the lab or something, and get it posted so that you'll have it. I'll remind you that we're only going to test you on the views that we have either covered in here or in the lab. So the things like, we've still got a couple of things to talk about in the wrist. So if you go, the last thing we talked about was the oblique and the lateral wrist on page 178, so oblique. So if you go just a few pages further, you'll see there's a specialty view for trapezium, and we're not going to cover it. There's one for carpal bridge, we're not going to cover it. Carpal canal, we're not going to cover it. So if we don't talk about them either in here or in the lab, don't waste time on them. Amy will cover those in your sophomore year. Okay, so, but we do need to talk about some specialty views of wrist. If you remember, the oblique of the wrist shows us the carpal bones on the lateral side of the wrist. Also remember, whenever you're taking a test, lateral side is from anatomical position. So it's always this side. This is lateral, right? This is lateral. Even if you go like this is still lateral, right? So make sure that you don't confuse that. That, regardless of what position you put the hand in, we refer back to anatomical position to determine medial from lateral. So what we see on the oblique of the wrist is we take the scaphoid and put it a little bit more parallel to the image receptor, so that we, if you have a fracture in the distal portion, the waist, or what they refer to as the waist, or the distal portion of the scaphoid, if in its natural lay, we might not be able to see it very well, so the oblique shows a little bit better. Unfortunately, we do have an increased OID, and with that increased OID, we do lose some sharpness of reported detail. But since it is the most commonly fractured bone of the wrist bones, not the most common fracture of the wrist, that's always going to be the radius and ulna, then we have some specialty views of it also. So I'm going to scroll back up, and we're going to take a look at where it is. You see it here. I'll magnify that up a little bit. You see it here, but what you see is a couple of things. One is that because the scaphoid is kind of shaped like a bent finger, from this point distally, it's at an angle from the image receptor. You remember the pin cap. If we've got some sort of angulation, you may not be able to see a fracture, subtle fracture. Most of your fractures at scaphoid are going to be pretty subtle. So it could close that fracture and you can't see it very well. And also you've got some superimposition between the capitate and metatarsal or metacarpal here. So you just can't see the whole thing real well, right? And certainly on the lateral, with the lateral, everything is superimposed, and the thing that you can see best is the lunate. So you can't really make a very good diagnosis, and you can see a little bit on the oblique, but you've also got an increase in superimposition there as well. So we have two specialty views of the scaphoid. One is what we refer to as ulnar deviation. And if you look at this, what we've got is the hand bent towards the ulna. Okay, so you don't have to have the patient with their fingers flexed like what you had on the PA, but what we're going to do is we're going to have the patient push their fingers towards the ulna. The ulna is over here, the radius is on the thumb side. And word association, what you're studying to be is an RT, so thumb and radius, right? They're on the same side. So you're going to flex towards the ulna, and it's going to desuperimpose. What's going to happen is the carpal bones on the medial side of the wrist are going to compress, but on the lateral side they're going to expand, and you're going to get a less superimposed scaphoid. So that's one thing. And I can tell you from experience, I fell and did some serious damage to my wrist. I had to wear a brace for about a year. Couldn't do anything with that wrist. And it was my dominant hand. That was real fun. But this hurts. If you've really got some damage to your carpal bones or the ligaments and tendons in your wrist, this hurts. So you're going to have to talk to your patient, talk them into, slowly ulnar flexing the hand. Okay, so let them take their time and get it over there. They can get it there, but it just takes a little bit of time. So that gives us a desuperimposition of the other bones in the wrist. And then if you flip over to page 182, what you'll see is what we refer to as the Stetcher Method. And the Stetcher Method, what it does, you know, with the ulnar deviation, we'll get the desuperimposition. But again, our scaphoid is going to be at an angle, the distal portion of our scaphoid is going to be at an angle to our image receptor, so it could close up the fracture line. So what the Stetcher Method attempts to do is put the central ray perpendicular to the anatomy that would be at an angle to the image receptor. And so if you've got a fracture line that would mimic that joint space, when we put the central ray, you know, perpendicular to that anatomy, it's going to be parallel to that joint space, and therefore open the joint space. And if in this analogy the joint space then is the fracture, then we can see the fracture a little bit better. Okay, so that's the Stetcher Method. And you got a couple of different options for the Stetcher Method. One is that if you happen to have a 20-degree sponge, you can put your image receptor on that sponge so that it is at an angle and your central ray is going to be perpendicular. Well, it's going to be vertical. It's not going to be it'll be perpendicular to the floor, but not the image receptor. So what I mean by that is if this is the sponge and this is the image receptor and that sponge is angled 20 degrees, the image receptor is also going to be angled 20 degrees, and then your anatomy is going to be angled 20 degrees. Does that make sense? Okay, so the opposite, or really not opposite, but a different way to do that would be to have your anatomy just flat on the image receptor, and instead of having the anatomy at an angle, you angle the central ray 20 degrees cephalic. Okay, so in both cases, they're going to be, you know, if you look at the collimation in the textbook, the collimation seems to be a little excessive, right? You're looking at a bone that's about the, I don't know, maybe the size of the last digit in your pinky finger, right? But if you look at the collimation says that you need 2.5 inches proximal and distal to the wrist and 1 inch on the sides. Okay, well, the 1 inch on the sides is to compensate for possibly your collimators not being accurate. So that's understandable. 2.5 inches on both sides of that, though, would kind of suggest that maybe they knew that this was a problem beforehand, hadn't done a wrist series, and you're including the distal portion of the radius and the ulna to possibly catch those fractures as well. So if you've already done, and this is just clinical correlation here, you know, the textbook answer is the test question answer, so it'd be 2.5 inches. But your clinical correlation there is if you've already done the PA oblique and the lateral wrist, you can collimate this thing down to almost nothing in both cases, right? So little bitty area of collimation, your central ray should be to the scaphoid. Scaphoid again is on the lateral side of the wrist, so it's on the thumb side of the wrist, and you know, either 20 degrees cephalic angulation or use that 20-degree sponge. So you got two different things. One is ulnar deviation and one is a Stetcher Method. Stetcher Method being that 20-degree angle, however you accomplish that. Every hospital I've ever worked in combined those two things. Okay, so again, clinical correlation. I've never worked in a hospital. Maybe a doctor's clinic might do one individually, but I've never worked in a hospital that didn't do both of them at the same time. So don't be surprised if you see the text doing that, both using the ulnar deviation plus the 20-degree cephalic angulation. That's probably what you're going to see clinically. Okay, so that's generally physician's choice, preference, hospital preference, protocol. You don't see it in the textbook, but you'll see it in clinicals most likely pretty regularly. So again, that's the ulnar deviation, the Stetcher Method. It kind of looks like a PA wrist on a hand that is just a little weird looking, right? So the bones look like they're a little bit stretched out, and that's because of that angulation. You get distortion, elongation of the anatomy. All right, so we're going to skip through our carpal canal, and we're going to go into our forearm, elbow, and humerus. So some of these things we're going to talk about kind of at the same time because some of the positioning is going to be identical on some of these. So we're going to talk about, we're going to kind of combine some of them. Now, in anatomical position, what your anatomy looks like is this, okay? So your radius and the ulna are parallel to each other. Whenever, if you stick your hand out with palm up, palm supinated, and then you pronate your hand, what's gonna happen is this over here doesn't move that much. You see this round thing here, it kind of looks like a plateau. Oops. Kind of looks like a plateau on a mountain range, right? It just comes up and it's flat, but it's circular. If you were to look down on it, it's actually really, really round. So your rotation comes from the articulation with the distal portion of the humerus, which would be right here, and this thing. So whenever you go from pronation or supination to pronation, pronation to supination, what's happening is you get rotation there, and then your radius crosses over your ulna. Okay. So if you have potentially any kind of position or any kind of anatomical issue, fracture or whatever, your ideal situation is to not have that happen, right? So what you want to have is the positioning, kind of like what we talked about in the wrist. If you remember in the wrist, I told you wanted the shoulder, elbow, and wrist all in the same plane, so that it externally rotates that that ulnar styloid process. Well, for the forearm and the elbow, we're going to do the same thing. Put everything in the same plane if at all possible, for some of the views anyway. So what you're going to do is you're going to extend the patient's elbow, so we're pretty much all in the same plane here, right? What you don't want to do is have the patient sitting upright and their elbows out like this, okay? Because the problem there is that you're going to get superimposition over the proximal portion of the ulna. That's what we refer to as the olecranon process. The olecranon process is going to have superimposition, more soft tissue over it and over the proximal radius and all that. So you want it fully extended, if at all possible. You want fully extended and the palm upright. So I'm kind of getting ahead of myself a little bit, so let's just focus on the bones first. You've got the radius and the ulna. The ulna is on the medial side, radius is on the lateral side. The smaller anatomy, we've got in the ulna, we've got the olecranon process, that's this thing here. And the coronoid process is on the anterior portion. So the olecranon is the back side. That's what, if you extend your elbow, that's kind of what stops your elbow from hyperextending, right? That's a thing on the back side. But the coronoid process is this thing right here. It's that little point on the anterior surface. And then you've got the styloid process, which we looked at before. So in the radius, we've got the radial head, and that's that round thing right there. And then you've got the radial tuberosity, and that's really where the soft tissue plugs in so that you can rotate your forearm. All right, so on the test, there's a drawing, or there at least used to be a drawing, where these two are kind of superimposed. So if you look at the ulna, is there anything that's an indentation into the ulna? Right here. So from a line drawing that's not shaded, sometimes it's difficult to tell on a test what it is that you're looking at if two things are superimposed. So if you've got something that looks like an indentation, you've got this line here, and then you've got this indentation that's kind of coming into this, what do you suppose that would be? It's radial tuberosity, right? So don't let that confuse you. The copies on a test sometimes just aren't as good as what you see out of the textbook, but that's what that is. Again, I don't know if that drawing is gonna wind up on this test or not, but if it does, just know that there's no indentation on the ulna. That's radial tuberosity. Okay. All right. So in the elbow, what we've got is a number of different things. We've got the same things that we talked about before, and it's what we refer to as a humeral ulnar joint. on the ulnar side, so the humerus kind of fits down into that U shape between the olecranon process, which is posterior, and the coronoid process on the anterior side. Notice that the radial head does not wrap around at all because we want it free so that we get that rotation. Now on the humerus, it's the biggest bone in the upper body, second biggest bone in the body, second only to the femur. The tibia probably gives us a run for its money, but it's a big bone and it's truly a long bone. All right, so we've got a lot of different features on it. We've got the radial, the humeral head. Just below that, we've got what we refer to as the neck, and that's commonplace for those fractures that we talked about before. You know, we talked about compression fractures, and we talked about the other one that seemed like a compression fracture. I'll think about it here in a minute. But what we get a lot of times in older patients is a fracture of the, sometimes we'll refer to it as surgical neck, where the patient falls, catches themselves, may have an associated wrist fracture that we'll take a look at different types of fractures here in a bit. But sometimes the shaft of the humerus will just shove up into the head. So that's where that occurs. So the head articulates with the scapula, and we'll take a look at that as well. And the distal part forms an elbow. So this is kind of stretched out. Let me see if I can make it look less weird. It appears I can't. Okay, there we go. That looks a little more normal. Okay, I feel better about that. All right, so we've got the head, we've got the anatomic neck, we've got the surgical neck here, we've got the greater tubercle, and we talked about this last week. If we're going to have a greater tubercle, then naturally we're going to have something else that's going to be called the lesser tubercle, and that's here. So we're going to talk about in rotation where we're going to see each one of these. Okay? So then on the distal end, what we have is a epicondyle. Remember, an epicondyle is something that's above a condyle. These two are your condyles. All right, so you've got a medial condyle, lateral condyle, and then the condyles, epicondyle. The condyles themselves are called the trochlea and the capitulum. So we couldn't make it easy, right? Trochlea and capitulum. Where do you see those words in normal conversation? Right? So I'm going to tell you how to kind of keep those straight here in a minute. And then you've got the coronoid fossa, which is on the anterior side, so that if your elbow is in very acute flexion, that the coronoid process has a place to go. And on the back side, what you're also going to have is an olecranon fossa, so that when you extend your elbow, it's got some place to go. So the distal portion of the humerus gets kind of thin right before it expands out for these condyles. Okay, so let's go back up to this image right here. Okay, so you've got two condyles. You got your epicondyles here. Those are the things that you can actually feel. The condyles are the articular surfaces. So you've got the olecranon fossa right here, and you've got the olecranon process right back there. You've got the coronoid process here, and you've got the radial head here. Okay, so who has ever popped a hood on a car and looked at the engine? Okay, most of you, if not all of you. If you haven't, do it. So you pop the hood on a car, and what's way up front that's full of fluid that, you know, as you drive down the road, it takes in air and it cools your engine down? Radiator. It's a radiator, right. So in your house, a radiator warms your house up. In the car, the radiator cools your car down, right? So sometimes you'll leak fluid out of the radiator for whatever reason. Maybe you got a hole in a hose or something like that, and you have to add more to it. So if you're going to unscrew something and you're going to put something in that thing that the container that you unscrewed, what's that thing that you unscrewed?
Cap.
Cap. It's a cap. Okay, so it's a radiator cap is what you're looking at. All right, so what bone is this?
Radius.
Radius. That is the capitulum. Right. So if you remember that association, radiator cap, radius capitulum, then the other two go together, right? I mean, you got to know the words, right? But you don't have to remember what goes with what if you just remember one of them. If you remember these two go together, then the other two go together, okay? So just remember radiator cap. All right, so all this stuff is really, pretty much a repeat of what we've talked about before. Dress the patient, take off watches, take off bracelets, take off, whatever can come off the patient for this particular exam, or the exam that we're going to be discussing at the time. It needs to come off the patient, right, if at all possible. If it won't come off, then, that's okay as well. But try to take anything off of the patient, give it to the patient, and, consider body position. If you got a fracture of long bone and the patient comes in a specific position, you might want to leave them in that position, okay? And it doesn't necessarily have to be long bones. If anybody ever had any kind of shoulder injury? Yeah? So with a shoulder injury, does it hurt to sit down and lay up, or sit up and lay down? Yeah. And so there's a lot of positional pain. So if you've got a patient who's got a shoulder injury and they come to you on a stretcher laying down, you've got one of two options. And both of those really pretty much involve shooting them on a stretcher or putting them on the table, right? So if they're already laying down, just have them scooch over onto the table and you can shoot them with them laying down instead of setting them up. If you choose to set them up with the bed. Okay, so consider the patient's position, consider the pain that they may be going through, and try to move them as little as possible, if at all possible. Sometimes you can't get around that, but if at all possible, move them as little as you can. So we're going to talk about image receptor and collimator size and orientation specific to the anatomy. So we'll save that. SID for the most part until we get to our shoulder, specific views of the shoulder. Our SID is always going to be 40 inches for the most part anyway. If you shoot at 72, if that's protocol in the hospital or the clinic you're working in, that's fine. But textbook SID is going to be 40 inches. So our forearm, we talked about this a little bit. So we're going to do two views of the forearm. One is put everything in the same plane, have the patient, get low, or build the image receptor up so that you can put everything in the same plane. So forearm, our central projection is going to be AP and lateral. Consider also that the patient may have some elbow involvement with their forearm. So what I would recommend that you do is for forearm, elbow, or even humerus, if the patient comes in, they're really favoring that arm, then maybe don't lock yourself into, our an order of operation, right? So we have a tendency, because we start off with a chest x-ray, we're going to do PA first and then lateral, generally speaking, right? Most of the time, that's how it's going to go. So we build kind of a protocol off of that, so we feel like we need to do AP before we do lateral, PA before we do lateral, and you don't, really. So let's say the patient comes to you and they're holding their elbow like this, they're holding their arm like this, and you ask them where they hurt and they say, here, Okay, so what did they just point to? Their whole arm, yeah. So the forearm hurts, their elbow hurts, and their distal portion of the humerus may hurt. So they may have involvement in multiple places. And some of those fractures, potential fractures, may be kind of subtle. And some of them may be a little bit obvious. So what we're going to have with our elbow, our humerus, and our forearm is that we're going to have a 90-degree bend in the elbow. Maybe less so for the humerus, but definitely for the forearm and for the elbow, we're going to have a 90-degree bend in the elbow, okay? And in both of those projections, we're going to have the thumb pointing straight up at the sky, okay? So for elbow and forearm, this is going to be your position. Everything in the same plane. bent 90 degrees, if at all possible, thumb pointing up. Okay, so again, the patient presents to you and they're holding their arm like this. What position are they almost in? Lateral, right. So start there. Just have them, bring their elbow up, put it on the image receptor, and now what you've got to do is just rotate the thumb and point it at the sky. Now you can look at the lateral, and your patient's going to always ask you, is it broken? They're always going to ask you. You have to tell them. And the doctor's got to make the diagnosis, right? But you're going to see an obvious fracture. I mean, it's obvious fractures are obvious, right? So then, once you see the lateral and determine whether or not the patient's got an obvious fracture, you can determine how insistent you be with the patient to get a good AP, right? So if they've broken their olecranon off, how willing are they going to be to just straighten their elbow out like that? Yeah, good luck. Good luck. And remember, you're not going to force them to do anything. You can suggest, you can try to cheerlead them into it, but it's all up to the patient whether or not they're going to straighten their elbow out. So take a look at the lateral, and then if everything looks good, then try to get them talked into extending the forearm to get an AP. So because we don't want the ulna crossing, or the radius crossing over the ulna, we're going to do our APs with the hand pronated. So let's say we're doing a forearm and you can see clear fractures of the radius and the ulna. Are you going to try to talk your patient into doing that? You might ask them, can you, put your palm up? And if they go, then you're just going to shoot it however it is, right? Because in a lot of cases, again, you've got the radius and the ulna. They're long bones, right? So if you've got fractures across both of those, and then you try to start rotating them around, then the bones can start grinding on each other. They can pinch soft tissue. It's just a bad situation, right? So you can ask the patient, certainly ask the patient. Go ahead and ask the patient, but if they show any kind of hesitance, you're just going to shoot it as it is. Okay? So what you're going to see then, and your central ray, again, we're looking at the forearm, so your central ray is going to be where? Middle of forearm. Middle of forearm, right. So it gets a little bit more complicated when we're talking about collimated field. Okay, so your ulna has a olecranon process which extends to about right here, right? So you can kind of feel it. You extend your elbow and you kind of feel it, and it's right about here. But get this up. So if it's right here, what am I getting into? Humerus, right? So your central ray needs to be the middle of the forearm, but your collimated field needs to be high enough that it includes the olecranon process. You also need to make sure that you include all the carpal bones as well. So your central ray, center of the forearm, and you're probably going to include maybe half of the metacarpals, and then the distal portion of the humerus to make sure that you include the radius and ulna. So you're going to need a big image receptor. If you happen to be working somewhere that has multiple size image receptors, you're going to have to use the big one. And if you can only find a smaller image receptor, then you can make this bigger than what it is. And what I mean by that is that, am I going to include my entire radius and ulna here? Probably not. Can I here? Yeah. Okay, so this applies, to 3 different bones or, exams. So humerus, to a lesser degree, the forearm, but I guess 3. And then the tib fib. And I'll tell you why it doesn't really apply to the femur whenever we get into lower extremity. But you can put the anatomy kind of catty-cornered from one corner to the other and extend it so that, what you really need is not just the anatomy, but you need to extend about 2 inches on either side. And the reason it's that much is because of the divergence of the central ray. What happens with the divergence of the central ray is a phenomenon we call parallax. All right. So if I have this right in the middle of my light field, what shape is it? Circular, right. Now I want to try to do this without moving, the orientation of this. As I go out this way, what happens? Cylindrical, right. So it's impossible for me to move out this way without moving it some, but you get the point, right? Because the light field, the most perpendicular portion of the light field is right dead square in the middle of the screen. That means that everything away from the middle of this is at an angle. Okay, now apply that to the X-ray beam. So the X-ray beam comes from a very small point, and if you put the middle of that right here, that's going to be the least distorted, and everything else is going to be at an angle. So even if you come all the way up to the elbow joint, you might not get all of the radius and ulna even. So you've got to go about 2 inches above and below because of the divergence of the central ray. Because of the what? Divergence of the central ray, right. All right, so that's what it should look like. Again, see this dark area right here? That is the olecranon fossa. That's where the olecranon process goes. Okay, so it's a thin part of the distal portion of the humerus. So you got to get from above that all the way down to the distal row of the carpal bones, at least maybe even half of the metacarpals. So your lateral of the forearm, where we talked about everything in the same plane, thumb pointing up, elbow bent to 90 degrees, and just make sure that you include about 2 inches distal on both ends as well. Okay, and that's what it should look like. All right, so also though, while we're here, you're going to get orders sometimes for multiple exams, and sometimes it's legitimate, sometimes, frankly, it's not. So, some of your doctors, some of your ER docs like to just order everything, and there are legitimate reasons to shoot individual things. Like in this case, because of the divergence of the central ray, are you going to have distortion of the wrist bones? Yeah, because of the divergence of the central ray, it's going to be as if you shot the wrist bones with an angulation on central ray. Are you going to have distortion of the elbow? Absolutely. So if you get a set of orders on a patient, and some of your patients just can't identify where they hurt, can't pinpoint it. They say, you hurt here, you hurt here, you hurt here, yeah. And they're going to order all three, okay? And that's a legitimate reason to order all three, is because of that bone is so long, you get so much divergence of the central ray that you get an ugly image of both the elbow and the wrist bones. So you got to shoot all three: elbow, forearm, and wrist. Okay. Is there a reason to shoot finger and hand separately? No, there really isn't. But some of your docs are going to order that. All right. So with the elbow, what we're going to do is we're going to do a number of different things. AP, lateral. And these are positioned again identically to the AP and the lateral of the forearm. The only difference here is going to be central ray location and collimation. So central ray location for the elbow is going to be at the elbow, right? So in this case, what it would be is a lateral condyle or epicondyle. So central ray location collimation is the only difference between them. But we are also going to talk about a couple of different obliques, and that would be a medial rotation oblique and a lateral rotation oblique. In both cases, those epicondyles are going to form what degree angle? There you go, very good, 45-degree angle. We haven't gotten to anything except for 45-degree angles yet, okay? Until we get to the shoulder, we're not going to. So 45-degree angle. And then we're gonna have a semi-specialty view if the patient can't fully extend their elbow. Maybe they truly have some elbow trauma and they can't extend their elbow. We're gonna have to compensate for that. And that's what these are, partial flexion for the distal humerus and partial flexion for the proximal radius malleus. So AP and lateral, again, we already talked about that, and that's what it should look like. And notice that's what I was talking about. So what is that? The superimposition of the radial tuberosity, right? So that's actually, you know, looking at that, would you say that's in front of or behind?
Behind.
It kind of looks like behind, right? But it's not, it's in front. If it was behind, you'd have a harder time, you know, rotating. So anyway, you've got that. Lateral. Okay, so something we haven't talked about yet, and I don't think is on this test, but every view of every anatomy has one view that's more important than all the other ones. For whatever reason, you know, the PA chest x-ray shows you more information what the lateral does because the lateral has so much superimposition, okay? And in the wrist bones, you've got views that are more important. In the elbow, you've got, you know, views as well that are more important. So what we have in the elbow and the lateral is that one. So I'm going to talk about this and tie it into why it is you can't shoot lateral elbow and a lateral forearm at the same time. So what you've got when we make a diagnosis, obviously we're looking for the integrity of the bone, right? Is the bone broken? Is it displaced? But sometimes it doesn't show up. So you can have a fracture of the elbow and the fracture itself might not show up for 2 or 3 days. So the swelling has to do its thing, and you know, if you've ever known somebody who maybe their child had a fracture, fell and broke something, went to the ER, they took x-rays, they said it's not broken, but you know, follow up with an orthopedic surgeon or whatever in a couple of days, and a couple of days later they say, yeah, it is fractured. That's not because the ER doc's quack. Sometimes the fracture just doesn't make itself visible for a couple of days, okay? So we have telltale indicators that we have fractures, and some of those are what we refer to as fat pads. And we're going to talk about this more next year whenever we go back through all this in radiographic critique. But in your elbow, you have 3. And what a fat pad is where 2 soft tissue structures are separated by different density of soft tissue, probably fat. Okay, so you got muscle, ligament, and then you got fat in between them. So in thin anatomy, you can see the difference. If you've ever seen not this one, but an elbow or a hand or a wrist, what you can see is different levels of density in the soft tissue. Okay, so in fat pads, what they should look like is they should follow the contour of the bone. So you've got 3 in the elbow. So you've got 1 on the distal portion, just anterior to the distal portion of the humerus. You got 1 just anterior to the radial head. So let me scroll back up and let's see. Okay, so what do you see on the radial head here? Right there. Superimposition, right? So what do you see on the radial head there? Superimposition, right? So in these views, you're not going to see a lack of superimposition on the radial head at all. So what we might look for is that fat pad that should follow the contour here, and if it's bowed out away from the bone, that's a telltale indication the patient has a fracture we can't see, okay? So we might have to do some specialty views of the elbow that we don't always do. Some of our hospitals, I'm just going to throw this out there because who's at UT North? Okay, so I think y'all routinely do a 4-view elbow. So if you see that come across the, an elbow coming across the, the computer, you're probably going to do a 4-view elbow. Most of the hospitals are just going to do 2-view. Some hospitals will do a 3-view, and I'll tell you which one of the obliques that is more routine than the other. But if you just do a 2-view and you see that fat pad bowed away from, and don't strain to try to see a fat pad. There's no fat pad in this. This might be a positioning dummy, I don't know. But if you see that fat pad bowed away from the anatomy, that's a telltale indication the patient may have a radial head fracture. So if the anterior fat pad, if it bows out, it takes on a distinct appearance, and it bows out. It's closer to the bone at the top, and it bows out kind of like a sail on a 1700s pirate ship. We actually call that the sail sign. Okay, and that's an indication the patient may have a fracture of the distal humerus. The third one sits inside the olecranon fossa. Okay, so both of those might indicate a fracture. They might not indicate a fracture. But the third one is harder to displace because it sits inside the olecranon fossa. So it's kind of sunk back into the bone. And if it's displaced enough that you can see it, there's a fracture there. You just might not be able to visualize it. Okay? So I say all this to say 2 things. Number one, this is the most important view of the elbow. Okay? Because you just don't see any of those on the AP. In the wrist, you see some fat pads on the AP and on the lateral, but you only see those fat pads on the lateral elbow. Okay? The second thing is you can't do a lateral forearm to show a good lateral elbow because it will project the kind of like rotation. It'll project that I guess that would be it's not on the test, but I guess that would be the lateral side of the elbow posteriorly, and it'll cover up that fat pad. Just can't do it. Okay? So if you truly suspect the patient may have something going on in the elbow, if the patient is truly, the doc ordered forearm, or the patient's complaining, I got pain right here, you might want to go back to the doc and say, hey, can I shoot an elbow on this guy? I think we might be missing something. So remember, you're a patient advocate before anything else. So if the patient's complaining of pain in a specific spot, you might want to get a look at it. So that's fractures. So you can have fracture of radial head, distal humerus, proximal ulna, anything. But you can also have dislocations without fractures. All right, so your mileage may vary on this, but 100% of the patients I ever had with a dislocated elbow came in a totally different presentation than somebody with a broken elbow. Okay, broken elbow always came to me like this. All right, so shot the lateral first, took a look at it, and then worked on the APs. Dislocated elbows, again, you may see a dislocated elbow where the patient comes to you like this, but 100% of the time that I've had dislocated elbows, patient came holding their arm like this. Okay, so what a dislocated elbow is going to do is that the humerus is going to pop out of the olecranon process, and it's going to be up here. Okay, so imagine bending your elbow where your bone is out. Yeah, it's going to be really, really painful for the patient. So if your patient comes to you and they're just holding their arm like this, what I recommend that you do is do nothing except for get the image receptor under it, take an image of it, and see if you've got a dislocation. If you don't have a dislocation, they're being dramatic, They might have a fracture, but they don't have a dislocation. And then you start working on other things. All right? So what if you have a patient that comes to you and they're holding their arm like this, and you ask them, can you straighten your elbow out? And they say, and they can only go about like this. You're going to do the 2 views. So what you're going to do, and we're not going to spend just a whole lot of time on this because they're accessory views, and they're positioned kind of like the other APs of the elbow. But what you're going to do is you're going to do a partial flexion. Okay, you may have to support the forearm because they don't want to straighten it out. They're, you know, they're in pain, so they're not wanting to straighten it out, so you may have to support it a little bit. And you're going to shoot partial flexion with the humerus parallel to the image receptor, essentially right perpendicular to the elbow joint, or to the distal portion of the humerus, for the distal humerus, right? And then you're going to take a second one with the radius and ulna parallel, okay? Neither one are going to be ideal. Both of them are going to be kind of ugly, especially right in the elbow joint. But remember, this is your most important view. So you maybe see the fracture on the composite, you know, partial flexion AP, that's two partial flexion APs. Every time you do that, it's going to be two. And then possibly see your fracture on lateral. Okay? Everybody good with that? Okay. So why don't we pause there, and we'll come back and we'll talk about obliques of the elbow and go further up into the humerus and shoulder. Any questions?